Good morning, everyone, and thank you for joining our EDC Coffee Chat, Coffee with Colleen. We're happy today to have on Kelly Cook, who is the Clinical Director of Outpatient Services for Peninsula Behavioral Health. And she's going to review a lot of the programs that Peninsula Behavioral Health has for our community. So we're really happy to have her, and it's such an incredibly valuable service that PBH provides. And I know they've grown enormously over the last years. And, just especially through COVID, the need became even more pronounced. So we just all think of you as such a critical element of our community in Clallam County. So thank you so much for being here. Just a few housekeeping details. If you wouldn't mind putting yourself on mute so we don't inadvertently pick up any background noise. And then if you have any questions, we like to make this interactive. So please raise your hand, or alternatively, you can put your question in the chat and I'll call on you to see if you want to ask it, or if you don't come on, I'll ask it for you. So with that, Kelly, I'll let you take it. And again, thank you for joining us.
Thank you for the invitation. It's great to be here. So as Colleen had said, my name is Kelly Cook, and I have been with PBH for about 9.5 years. I am from New Jersey originally, and I have a master's degree in social work from Rutgers University, and have worked in community behavioral health in South Carolina, where I lived for about 4 years and came here, and the rest is history. So I've had several different roles here at Peninsula Behavioral Health. They've all been in the clinical realm, so a lot of clinical supervision, supervising therapists and interns and the case management department. So today I'm here to talk a little bit about our services, and also just really want to know what your questions are. So, sometimes people have really specific information that they'd like to know about PBH. It's a very large organization that does a lot of different work in the community. So I welcome any questions that you have. And my focus here at PBH is really overseeing the clinical services, the outpatient services. So some of the bigger picture topics, legislation. I know the ones that affect clinical really well, but if there's anything that I can't answer, I could certainly get answers from Wendy Sisk, who knows a lot more about the bigger picture dynamics.
So Kelly, what services do you guys have that are not outpatient services?
So the distinction between outpatient and our other services is outpatient services are considered for folks who've had an assessment and haven't been given specific recommendations about treatment. And the other side of our services are outreach services. So people who are not enrolled in our outpatient care, but they are, working on being engaged perhaps to come here, or they may not need our services, but need that outreach care. Also, our crisis services are not considered outpatient. Crisis services are available to anyone in the community, whether they have an enrolled status or not at PBH. And also our residential services are kind of on that side of the house as well.
Okay, got it. Thank you.
Yeah. So I have a very, very brief PowerPoint to sort of guide discussion. So I'm going to share my screen, and I already realized I forgot several things. Colleen, can you give me permission to?
Yep, I did.
Oh, you did? Okay.
Yep. Should be able. Oh, nope. Now I did. I lied. I did the first time around.
I was like, it could be my technology issues. It's one of those mornings. Aha. Okay. All right. Can you see that screen?
Sure can. Thanks.
All right. So again, I always like to start with, does anyone have any specific topics that they would like covered or discussed? Does anyone have anything that they would like me to address?
I want to hear about new journeys and when you expect that will kick off and what is that about and how were you guys able to get that in Clallam County, that program?
Perfect. Okay. Any other topics that you'd like to hear about?
Yes, this is Dale Jarvis. I'd like to hear about the work that you're doing integrating behavioral health with primary care.
Okay, great.
And it looks like Pat McCauley put in, she'd like to hear about your work with homeless teens.
All right. Any other topics? And if you don't have any now, we can jump into more later.
Right.
So just an overview of PBH. As Colleen had mentioned, we have grown tremendously over the past several years. When I first started here, I think there was 83 employees, and we're hovering around 140 employees now. And that has a lot to do with just a lot of growth of programs, additions of programs at PBH. So we have several clinics. We have the main building, as most people call it, or the 8th Street. And in this building, we have the full scope of services for adults. We have medication management here. We have therapists here. We have case managers, care navigators, substance use disorder, and our crisis services. We also, as you know, have the children's building across the parking lot. And I forgot to add this in the PowerPoint, but the children's building and the Clallam County Respite Center, which is our 6-bed crisis stabilization program, is also across the parking lot. And as some of you may know, we have recently opened a new building in Sequim. So we did have a building, a very small building in Sequim that we had been operating out of for quite a while, and now have a much nicer, bigger space that is it's split into two. So we have the right side of the building open right now, and that has therapists and psychiatric ARNP. And folks from the main office also float to that building, and soon we'll be opening the left side of that building as well and increasing our available space. We also have several residential programs. So we have 3 transitional houses. We also, as you probably know, have recently opened Dawnview Court, which has 25 units. That's a pretty outstanding program, and it's completely full. And we're all really excited about this. This has been an incredible game changer for all of our folks that live there. People have been able to be reunited with their children as a result of having stable housing. So this is just a really exciting program. It's a great team of folks that are running this.
And
So
Kelly, is that
yeah.
facility filled?
Oh, it's completely filled. Yep.
Is
Yep.
there a waiting list as well?
There is a waiting list. Yes, we had
Okay.
a lot of applications leading up to that. We had, I mean, just more than we could possibly be able to serve.
Mhm.
But it is full and there is a waiting list.
And can, just for folks, what does ARNP stand for and how is that different from a psychiatrist?
Sure.
A
So
psychiatric ARNP.
it's, I don't actually know what the A is, but the the psychiatric nurse practitioner. So we have, I think, 5 psychiatric nurse practitioners, aka ARNP. I'm not 100% sure of that acronym. Some folks call them NPs. So they have the ability to treat folks, to prescribe medication. I am not sure what the educational difference exactly is. So I know that most psychiatric nurse practitioners get a master's degree plus several years of uh, essentially internships or clinicals. So I don't want to misinform. I'm not 100% sure what the educational requirements are for ARNP, but they have the full ability to prescribe and treat folks with mental health conditions.
And do you guys currently have a psychiatrist on staff?
We do not.
Okay, you did though.
Yes, we had Dr. Sarah Lewis was
Uh-huh.
here, but she is no longer with us. So we have our medical director is also a ARNP.
Okay. And are you guys trying to get another psychiatrist? I know they're really hard to find, and I don't think there's one practicing in Clallam County.
You know, I
Josh
don't,
Jones is one, but he's not practicing. He's the medical director, I think, of OMC, so he's not actually seeing patients. And
yeah.
I know Known does not have one either.
I don't know what the medical department, what Joe Rice is our medical director. I don't know if a psychiatrist is being sought or not. The ARNPs are able to do essentially, I don't know anything that they can't do that a psychiatrist can do.
Okay, thank you.
Sure. So the clinical services that we have, so in the children's services, we have standard outpatient therapy, and we also have the WISE program, which is the wraparound intensive services program, which is a fantastic program for children and families. There is a team of individuals that work on a WISE team. So there is a therapist, there's a care coordinator who coordinates all the services and the meetings. There's also a peer support for the child and a peer support for the parent. So that is essentially what the WISE program is. Children, of course, have crisis services available, and there is medication management available for children as well. On the adult side of the house, there are multiple programs depending on someone's needs. There is a case management department, and our case management department does a lot of clinical case management for folks with serious and persistent mental illness. So that department really helps people who have more intensive needs, and they might need a lot of service delivery. So they might need to work with somebody on housing, on some real concrete benefits, also social skills, and maybe vocations. So that's what the case management department does here. Care navigation is similar. They help folks navigate through our services and also services in the community. They can also provide clinical interventions for folks like basic cognitive behavioral therapy, mindfulness. We have adult therapy. So the therapists here utilize a variety of approaches for delivering therapy. So of course, we always try to utilize evidence-based practices. So we do a lot of training so that we can stay current and also try to use as many evidence-based practices as possible. Some examples of the things that PBH therapists are trained in. Some folks have training in EMDR, which is eye movement and desensitization reprocessing, cognitive behavioral therapy, dialectical behavioral therapy, motivational interviewing. So there's a variety of different types of treatments that folks are trained in. We also have substance use disorder treatment, medication management. We have Horizon. The Horizon building provides day support. We have crisis services, PATH services, which is projects for assistance and transition from homelessness. So the PATH team is one of the outreach team that goes out and tries to engage folks who are experiencing homelessness and get them connected with services. PBH has a REAL team, which stands for Recovery, Empowerment, Advocacy, and Linkage. And the REAL team also is an outreach team that goes out and tries to engage folks and assist with linkage to substance use treatment and concrete resources. And the last program was New Journeys, and New Journeys is very exciting. It's considered to be an evidence-based first episode psychosis program. So similar to the WISE program, the New Journeys program is based on the belief that having multiple services wrapped around an individual is the most effective. So we are in the process of hiring folks for that team. On a New Journeys team, there are several roles. There is a therapist, a case manager, somebody who is working very hard on employment work with the individual. So, and also the provider, so the psychiatric prescriber is also part of that team. And the way that we were able to get on board with New Journeys, they actually contacted us. And the reason that we were reluctant to do New Journeys for the past couple of years is because they have an expectation of the size of the model, and we didn't really feel that we were able to support the size of the model that they expected in our community. And since that time, they had discovered that they were able to scale this model to meet communities that were not able to have the numbers that was typically expected in this program. And they approached us with a scalable model, which we were really excited to discuss with them. And based on that, we have been able to get things rolling and develop this program. So we anticipate that we should be able to, we are already compiling a list of folks that are going to be eligible or qualified for this program, but we'll be able to hopefully start enrolling folks in it, I would say, I don't know, they give us a year to 2 years sometimes it takes to develop this program, but we are hopeful that we'll be able to finish hiring for this, I don't know, within the next 5 to 7 months. So that's our goal, is to try to get things up and running within the next 5 to 7 months. There are some criteria that folks need to meet to be eligible for the New Journeys program. So it has to do with age, and it also has to do with length of illness, essentially. So how long somebody has been experiencing psychosis, and it also has to do with diagnosis. So there are a few different types of diagnosis that someone has to have to be able to qualify for this program. I'm going to stop share for a second. Does anybody have any questions about any of the services I just mentioned? Or
Well, I have a question. I've read about different types of treatment for people in psychosis, and one was transcranial magnetic stimulation.
mm-hmm.
Is that something you guys provide at PBH?
We don't currently have anyone that is trained in TCM.
Okay.
So not something that we're able to provide.
Okay. All right. There was a great question in the chat from, I think it was James. No, it was Lowell. Lowell, do you want to ask your question?
Yes, actually, I have 2 questions at this point. My first question is, what is your relationship and how are you working with the Jamestown Healing Clinic? And the other question is, considering that OMC is having financial difficulties and some of our providers leaving the area, can you tell us a little bit about your long-term financial outlook there at PBH? Thank you.
Sure. So unfortunately, I can't answer that question. That is probably more of a Wendy Sisk or Kathy Stevens question in terms of the financial outlook. That's not really within my scope, but I'd be happy to contact them if you're wanting that information. And to address the Jamestown Healing Clinic, so I don't know. I'm trying to think. I know that we have several touches with the Jamestown Healing Clinic, so that the REAL team works with the Jamestown Healing Clinic. We refer folks to the Jamestown Healing Clinic for services as well, if it's a service that we don't provide. Our care navigation department is, in my understanding, routine communication with the Jamestown Healing Clinic about mutual clients. So sometimes we share clients with Jamestown, sometimes we refer, sometimes we accept referral. So we do have a strong relationship that goes back and forth with Jamestown.
And how about with the new clinic they are working on creating? How will you interact with them where they'll provide inpatient services? And how many beds will it be? I don't recall. Is it 16?
Yeah, I don't recall the number of beds, but that's really exciting. I can't even imagine what it's going to be like for our community to actually have an ENT here, since we don't have one, as many of you know.
ENT?
So evaluation treatment, it's where someone can actually go to the hospital to receive psychiatric care. So we don't
And
have
so,
anything. The closest thing for us is Kitsap. So, everyone that has to go inpatient for psychiatric care has to leave this community to do that
mhm. And so
currently.
can you talk a little bit about that? I understand that frequently there aren't beds open, even if someone is picked up involuntary treatment. And is that the only way someone would go in there, or can someone voluntarily be checked into an inpatient treatment?
Yep. So Washington has a few different methods. So there is the Involuntary Treatment Act, which is basically a decision made between a DCR and a doctor, whether
And
someone meets
DCR?
designated crisis responders. So,
Yeah.
sorry, I'm just acronyms all over the place. So yes, in Washington State, a designated crisis responder and a doctor typically concur on the decision to admit somebody against, against their will, essentially somebody who is not voluntary, based on certain criteria, whether they are a danger to themselves or others, whether they're experiencing grave disability where they just can't make decisions for themselves. So that is one method of involuntary treatment. And then, yes, there is voluntary treatment. Anyone can go to any of these hospitals and say, I am not feeling well and I really want to be in the hospital, and they'll be evaluated for admission. Someone can also present at OMC and request voluntary hospitalization, and the social workers there can assist someone with getting into a voluntary hospitalization.
Mhm. Okay. And how many patients does PBH see now? And did that go up substantially over COVID? And do you think, has your patient load gone up just because you have more, like, have you always had a really long wait list and now you don't? Can you kind of describe that demand scenario?
Sure. So we currently have about approximately 1,800 active clients, and we annually touch about 3,400 people. So we might have active clients, this active population. Then we also have folks that we encounter through crisis services, folks that maybe don't enroll, but receive some other type of service from PBH. So I'm sorry, what was the other part of your question? Oh, demand.
Oh,
So
yeah. And
um,
over time, how has that changed?
yeah, so there has definitely been an increase in the demand for behavioral health services. Um, you all may know that there is a pretty significant behavioral health workforce shortage in the state of Washington. Let me click to my slide here.
And
So
I
that's a
believe Peninsula College is working with you on trying to create a program, right?
Yeah, yep. And I have a slide about that as well. And I'll talk about that because that is one of the strategies to address this behavioral health workforce shortage. So as you see here, this is a quote from UW's, the head of UW's Department of Psychiatry.
Mhm.
So it's pretty substantial workforce shortage that we're experiencing in behavioral health. And some more statistics. We have just one mental health provider for every 360 people. And there are about half of our counties in Washington that don't have a single psychiatrist. So there's a pretty big problem happening as the demand is growing. I think there's like a percentage-wise 30% shortage of the amount of mental health professionals that we actually need to do the job. So, and this is for a variety of reasons, but in terms of things improving, there are several legislative changes that have happened to help. One of them is addressing student loan repayment programs, so making that more appealing for folks entering the field. reducing barriers to actually being able to get your clinical licensure. So there had been some barriers and discrepancies between different credentials, and starting in July, some of those have become more equivalent. And focus on increasing educational opportunities, which leads us into Peninsula College. Starting this September, we'll be offering a BAS, which is a Bachelor's in Applied Science in Behavioral Health. So we have been working with them over the past 6 months to develop the curriculum and work with them to really say, hey, this is what folks in our community need to be trained to help with this workforce shortage, and assisting developing the curriculum so that folks who would like to pursue their master's after this will be able to do that as well.
Mhm.
And
That's great. Interesting. I just did some quick math, and 1,800 people that are enrolled in programs at PBH, and 78,000 people in our county. So that's 2%, 2.3% of our population receives services by PBH. And then, but that of course doesn't include those that are being seen at OMC or at, there's a couple private providers, I think, and, or then also Jamestown. So yeah, it's a big need.
yes, it is a big need. And some folks don't realize too that we have guidelines about the criteria someone has to meet to be admitted to our services as well. So that criteria is a diagnosable mental health condition as well as a functional impairment. So somebody also has to be experiencing impairments in their functioning. That's the work that we do here at PBH, is to help folks with, well, in part, help folks improve functioning.
Okay. Interesting. And so can you kind of share, is it mostly people with anxiety, depression, psychosis? How does that lay out from, your patient? And, or is it just a huge mix of all of
That's
the
a great
above?
question.
Or
It is a huge
PTSD?
Yeah, so as you probably know, there are a lot of high ACEs scores in this area. So
What is that?
ACEs is a basically an inventory of traumatic experiences that's been very well studied. So the higher the ACEs score, that really correlates to outcomes in the future. So the questions on that survey are things, it's adverse childhood experiences scale. That's what the actual name of that survey is. So this community folks have higher ACEs scores that we serve. So early childhood experiences with adversity, traumatic experiences. So we have a blend of different conditions that we see. So definitely a substantial amount of post-traumatic stress disorder and substance use disorder, depression, anxiety, bipolar disorder, schizophrenia, schizoaffective disorder. I would say those are the primary behavioral health conditions that we work with.
Got it. Well, I'm trying to see if we addressed all the questions in the chat. Does anybody have?
There was a question about integrating behavioral health and primary care.
Oh, that's right.
So one of the things that we are doing, we have a general nurse practitioner, Christine Burnell. So she is our primary care provider here at PBH, and works with a lot of our folks who have a variety, a lot of layers of different types of issues, maybe a mental health condition and significant medical issues, folks that can be very complicated. So we do have primary care services here at Peninsula Behavioral Health. So that's one manner of integrating primary care with behavioral health.
And let's see, what work do you do with the homeless teens specifically, or with the high schools?
Homeless teens, that's a really good question. I am not quite sure if again, that's outreach services, so that's not under my direct view, but in terms of our outreach services, I am not 100% sure if they serve folks under 18. I can certainly find that out, or if that's if they encounter those folks, if they refer them to someone else. So I'm not 100% sure on that question, but I can definitely find that out.
Julia, you have a question?
Hold on. Okay, I'm unmuting. I was saying hold on while I was looking for the unmute, and I realized you couldn't hear me saying that. So I'm with Cloud Mosaic. We support people with developmental disabilities, and I'm wondering if you know what percentage of your population that you treat also have developmental disabilities, and are you set up to work with people that have kind of that dual diagnosis of developmental disabilities, but also mental health issues?
Good question. I don't know the percentage, but just from my experience working here over the years, and yes, we do, of course, have the training and ability to work with folks who have both a developmental disability and another mental health condition. I would, if I had to guess what was folks that were on the adult therapy caseload that also had a developmental disability, I would say approximately 25 people, 25 individuals. And the way that I arrive at that is we have something called the millage grant. This is actually not something that really exists anymore, I don't believe, but it used to be additional funding from the county to be able to serve folks with developmental disabilities that didn't necessarily qualify for the rest of the service package at PBH. But since Medicaid expansion has occurred, that's not so much of a problem anymore. So we haven't utilized that funding in a long time because we're able to serve folks a little bit more with Medicaid expansion.
Oh, wonderful. Thank you. That's really good to know.
Yeah. And we work closely with DDA. So we try to have
What's
a meeting,
DDA?
Developmental Disabilities Administration. So we've had a long-term relationship with DDA. We usually have staffings if we have mutual clients. So.
Oh, good. Just a shout out for our local DDA is really awesome. I'm very impressed with it.
They are awesome.
Are they in Port Angeles?
Mm-hmm.
Their offices are down by Country Air, down by the waterfront.
Got it. So what percentage of the clients are commercial payers? You mentioned Medicaid. Are just about the vast majority served through Medicaid?
Great question. I don't know the numbers. I would say our primary payer is Apple Health. So we definitely, that is the population that we are beholden to serve, meaning that we have certain timelines established to ensure that folks get in and within 10 days of the request for service. And so that is our primary population. We also do accept a lot of private insurances. And even if we don't accept it, I mean, PBH I think does a really great job at being able to get folks in who need to be seen here, regardless of the ability to pay. So that's something that I find really valuable about this organization also.
So when Daryl Wolf gave his presentation about their financial situation, he talked about one of the issues is that well, he talked about travelers and locums, and also, of course, they've always been a very high government payer mix, which the Medicare and Medicaid does not pay. I think Matt, you were there, so correct me if I'm wrong on this, but I think it is Medicare is at 60% of cost. Medicaid is generally 65% of cost. But that is going to go up. The Washington State Hospital Association lobbied to get that increased Medicaid from 65% to 95%. So that'll be an extra $10 million per year that OMC receives. But another thing he talked about was that if someone comes in that is under an involuntary treatment to the ER and there's no place to put them in because Poulsbo or Silverdale don't have any openings, then they have to stay in the ER for many days. And
Single bed
that
certification.
yeah, well, they'll certify, yes, they need to be involuntarily treated, but there's no place to put them for the 72 hours or more. So they just stay there in the ER. And that is very expensive for them. When Jamestown, their health clinic, mental health clinic opens up, will they do they still have to go to the ER first, or could they go directly there if a designated crisis responder determined, yeah, they need to be evaluated?
Great question. I don't know what the dynamics of that will be yet. So hospitals handle this differently. So some hospitals, allow people to walk in and essentially request voluntary. So I don't know what all the dynamics of that are going to be.
Okay.
So your big question there is, could somebody present, like if a DCR met somebody or they had a DCR, could somebody actually present there to be evaluated? It is possible. I just typically most always there's medical clearance involved before somebody becomes detained under the Involuntary
Got
Treatment
it.
Act. So that's always done at the hospital.
Got it. Okay. So they would go through the ER first, but we'd have,
I don't know,
locally a place to send
there
them.
has to be medical clearance. That's usually what the process is, medical clearance, to make sure that whatever they're experiencing is not based on a medical condition or influenced by it.
Okay.
And that they're stable for admission.
Got it. Sean has a question. Sean, do you want to, he's asking about Dawnview.
Sure. So Dawnview is the old Allview Motel. So it was converted into permanent housing. We have 25 units there. When I made the reference to families being reunited, that's actually a smaller portion of those folks. So there are a few folks there that were able to reunite with children based on having permanent housing. But yes, 25 units are full with community members who were experiencing homelessness.
And that's long-term, right?
Yes, correct. It's
Yeah.
permanent housing.
Yeah.
Thank you.
Yeah.
And a total of 25 units there?
Correct.
Yeah. Are there services there as well, and are those people, is it just, it was affordable housing, or was it people that also had been enrolled in PBH?
Yeah, great question. So you don't have to be enrolled in PBH to be eligible for that housing. So some of the folks that live there are connected with PBH and some are not.
Okay. Well, it was an amazing project.
It's beautiful. It's really, it's amazing.
That's great. All right. Well, does anyone else have any additional questions for Kelly? If not,
I do.
Oh, go ahead, Sean, please.
Thank you. Regarding patients that you might see, and I guess I'm looking for an example. Somebody comes in, they're in need of psychiatric care, but maybe they're deemed, I shouldn't say dangerous, but maybe they have kind of some violent tendencies, which, I mean, how do you guys handle that? Are you able to facilitate that? I'm asking specifically because of a situation that was recently brought to my attention where a young man needed help, but because of his domestic violence, restraining order with his brother, he wasn't able to get some services that people thought he might need. How do you handle situations like that?
We don't deny services to anyone. So in terms of like if somebody has a history of violence, we work with folks who definitely have a history of violence, who've been incarcerated, who are currently incarcerated. So
Do you help people at Clallam Bay Correctional Center?
no, we don't go out there. So we do work with folks in the in Clallam County.
Okay, at
Yep.
the jail.
Yep. We have
Okay.
some staff that go out there and actually meet with folks. Yep.
That's great. Good. Dale, go ahead.
Thank you. I really appreciate the challenges around a workforce shortage and the fact that Peninsula Behavioral Health has kind of like eligibility requirements that focuses on folks with more serious disorders. And I appreciate that you have integrated primary care inside your organization. The other half of that primary care integration model is to place behavioral health clinicians in local primary care clinics so that folks with more mild to moderate disorders can be served in that setting. And I can't remember whether that's a project that you all have taken on and gotten funding for.
Most of the primary care clinics have their own folks. So back when I think when integration was first really starting in this community, I believe that PBH held some contracts to assist some of the primary care folks with getting those behavioral health folks. But now most folks have their own existing behavioral health positions within their settings.
Got it. And one of the things that's challenging is that there's often lack of communication between the behavioral health folks in primary care clinics when they have a case that's more complicated than they can handle. And so in other communities, there's a really strong liaison process between the behavioral health clinic and the primary care clinics in order to provide that consultation. I know that you quoted Jürgen Unitzer, Dr. Unitzer from UW. They have a psychiatric consultation service out of UW. Could you say a little bit about, do you have any sense of what happens when a behavioral health clinician in a primary care clinic gets in over their head and needs help? Is there any backup that you all can provide?
Our care navigation team here does a lot of that work with assisting community partners and professionals with collaborating about cases. So our care navigation department has really, I think, helped with some of those issues that you're discussing to really help connect people and make sure that those lines of communication are open. And I know that our prescribers are always more than willing to consult and talk about things. So I know that occurs. I don't, have much more to say because that's not really my my world as much in terms of, the medical department here. But I do know that there is a robust amount of communication that occurs to connect prescribers to other prescribers and providers to providers.
Kelly, do you mind if Rebecca shares a bit about primary care integration?
Sure.
Go for it, Rebecca.
Hey, Kelly, I can't come on screen because my internet will go out, but I wanted to let people know that one of the huge complications with integrating primary care, that if I were to go to, say, North Olympic Healthcare Network for behavioral health services, known would get reimbursed at a higher rate than if I were to come to PBH for those same services. And so we've got, the whole system is trying to work itself out. There is not parity. And so the behavioral health clinics really suffer because of that. And it just adds a complication to it. And it doesn't seem fair that if you go to one clinic, that clinic's getting reimbursed at a higher rate. But that's the game of community health.
That's one of, not so much behavioral health, but Daryl was talking about, Daryl Wolf, CEO of OMC, that if a patient is seen by a primary care physician at OMC, the reimbursement rate is $60. But if they go to Jamestown, it's over $300, because
And-
they can bill for multiple things during that visit or multiple things in a day, whereas OMC is only allowed to bill once. So a lot of it is about the reimbursement rates from insurers, which I know Dale is a CPA and working with healthcare for years. I'm sure you're very aware of all of that.
If I could just add a quick comment about that. Any of the federally qualified health centers also get that higher rate because they get paid on a flat rate per visit basis. Just a little smidge of history. A handful of years ago, the legislation was passed in Congress to create certified community behavioral health clinics that would pay that same amount, that would get paid that flat rate that Rebecca was talking about. And Washington was one of a few number of states that said, we're not going to apply for that program. And so we sort of shot ourselves in the foot, and the state is turned around and trying to follow up. But I want to make it really clear to everybody that organizations like Peninsula Behavioral Health, excuse my French, have been screwed by decisions that were made by folks in Olympia a number of years ago. And hopefully that will turn around, because PBH is working on being a certified community behavioral health clinic.
Yeah, Julia wrote about how Jefferson, and I know Forks too, because I believe they have fewer than 25 beds, get reimbursed, Medicare reimbursement rates at a much higher rate than OMC does. I believe it's at 100. Go ahead.
Oh, it has something to do with the rural designation. And I can't remember, Angela, who used to be over at OMP as the head physician, was explaining it to me. And yeah, it just doesn't completely make sense, but it's what it is.
They've given carve outs to really small rural hospitals. But if you have more than 25 beds, I think it is, you're not considered really small. And so, yeah, the expectation is hospitals will close. Grays Harbor Hospital on a daily basis can only pay half of its bills. And so they're at high risk of closure. And, you know, the belief is it's going to take hospital closures for the federal government to do anything about it. All right. Anybody else have anything they want to ask or share? If not, I think I will go ahead and call it a morning. And once again, Kelly, thank you so much for joining us and educating us a little bit more about the services, the really incredibly important services that Peninsula Behavioral Health provides to Clallam County. So thank you so much for all you do.
Thanks for having us. Thank you.
Yeah, thanks. Have a great morning, everyone. Bye-bye.